Excellent. Now I think we're going to go to Dr. Kini live from the cath lab, giving us a talk actually on the work that she's done on the app technologies, but especially one in shock that I think you'll be shocked to see, shocked and awed. So, Dr. Kini, are you live? Are you ready for your talk? She is the
Yes.
Dr. Kini is. You see all of her titles, but most importantly, I think she's one of the rare women in interventional cardiology who performs the most complex procedures, who teaches her craft and her skill to everyone, who promotes everyone around her, and is kind and gentle, not only to her staff, but also to all her trainees, and is incredibly proud to be able to promote other women and men to levels of to high levels in interventional cardiology. And then in her spare time, I don't know where she sleeps, but not only is she doing all of these apps, but she's also done some of the most significant research that you just heard mentioned today, earlier today, regarding the imaging and understanding better about the atherosclerotic plaque, actually trying to put herself out of business. So she's very commendable because she truly is gifted and cares so much about patients. One of the things you don't know about her is that she's an avid yoga spiritual person and does lots and lots of exercise and constantly tells me that I got to get a better life. So I love working with her. She and I are great partners, and it has been a fantastic pleasure over the last 13 years to learn so much from Dr. Kini, and now she's going to tell us about the app technologies. Anu, you're on.
Thank you for the introduction, Roxana. And already from the previous talk, we learned that there has to be some change to save patients when they come in cardiogenic shock. So going to the etiology and clinical outcomes of cardiogenic shock, just to give a background. So 52% of the cases that present with shock are heart failure, and patients who come with myocardial infarction, about 32%. And very important to know that patients who actually presents with cardiogenic shock have a very high hospital mortality, almost 42%, especially if they are acute MI. And if they are outside hospital cardiac arrest, mortality goes up to 52%. And we all know cardiogenic shock occurs in about 10% of patients who present with AMI, with the mortality rate from 40% 30 days, 50% at 1 year when they have AMI. So we know when they come and you know that is some kind of a MI giving shock, we got to immediately take them to the lab and take care of the infarct-related artery. So what does the guideline say? Very clear that ST segment MI with cardiogenic shock, class 1 indication for lab as well as primary PCI. If it is a non-ST MI, still urgent PCI of the culprit vessel, class 1 indication. Now, there was a lot of discussion what kind of a support should be used in this kind of patient. It is class 2A, whether it is IABP, other kind of a mechanical support that we need to use. And everybody is very clear with the shock from SKY. People should know what the stages are. Initially came out in 2019, in 22, that was an update. So it's very simple to remember. A is at risk, B is the beginning of shock. Why we need to know? You need to know what the patient, examination also, and important already Amir Kaki mentioned was we got to know what's the lactate number that's happening in this patient. So I think starting from B, C, D, E, everybody has to know the number of the lactate is important because you need to follow this. So what is other important thing about cardiogenic shock? It's a dynamic process. Patient could recover or deteriorate. Exactly what was shown in the previous case, and I'm going to show you the same thing. And more important, if they have come with out of hospital cardiac arrest, everything changes in these patients. So recently shown also that B equal to bad. That B or that group of patients are usually do very poorly, and 90% are escalated to higher stages in hospital. And this is the recent publication that was there for what we do is the weaning. But there are three, whether it's cardiac, combined cardiopulmonary, or pulmonary, how do they recover, as well as the weaning algorithm. Based on all this publication, we created this app, which is called MCS8, which is very, it's free to download. So the app starts with decision-making algorithm, and of course there's a weaning algorithm. And then it will describe what kind of various devices that are available out there. And very important is you got to know certain important numbers. So we have a calculator. You can directly go to the calculator that's right there, understand what the numbers are, how those numbers are measured, reference values, and what to do with the patients when they come to you. So this is an example where we managed a case using this app, which is a 61-year-old male who presented with VF arrest, significant risk factors, had prior history of CAD, and no illicit drug use, which we always check when they come. So when he presented to the ER, already recovered, ROSC was obtained, blood pressure was 88, already intubated with bilateral crackles. So look at this, the early labs in the lab, which is creatinine 1.4 and troponin 3.1. First thing you do is you do an EKG, which already shows that AVR ST elevation, some ST depressions down, and we had to take this patient to the cath lab. So if you see, what does the app tell us? MCS decision-making algorithm, clinical presentation was patient cardiac arrest, post-ROSC, stable, and it was not refractory post-arrest, not a refractory VFib. So your EKG was STEMI, go to the lab. So we took the patient to the lab. So EDP was 32, EF was about 25. So you see a proximal LAD occlusion. And same, if you have less than 90, EDP greater than 15, based on the guidelines, we always say do an impella followed by the PCI, and that is what we did for this patient. So final angio, nice flow of the LAD. So what does, same thing, that was just discussed in the previous case, right cath was done in this patient. So if you do a right heart cath, borderline numbers. So CPO was 0.70 borderline. You got the goal has to be less than 0.6, which has to be, CPO greater than 0.8 has to be the goal. Less than 0.6 is low in this patient. PAPI was also 2, again was borderline. So what was done? We thought we can take this patient to the CCU, was taken to the CCU, but guess what? Within a day, he has multiple episodes of heart blocks, ventricular arrhythmia, and then CPO dropped to less than 4.0, PAPI also dropped. So everything, you can see how the app takes you, how to manage this case. So then we had to take the patient to the cath lab. When you have ventricular arrhythmia, first thing is that did the patient have acute stent thrombosis? So we made sure that stent patency was good. And then the plan was, as you see here, we went on to the ECMO. So subsequently went to the CCU and did very well, weaned him off the drips. ECMO came out in day 4 and impella was removed in day 6. Now the question is, why are we still seeing this? Now, if you see the publications, the STEMI workflow improvement, about 2016 or so, you see after that everything plateaued. So this is a non-transfer patient, door to balloon time is plateaued about 80 or so. And then if door in, door out for transfer is still about 58 or so. Why are we not able to improve these timings and save life? This was a publication that came out in JAMA last year and was a presentation in AHA. Only 1/4 of the patients, if you see here in this 1/4, that met, and that to a goal of less than 120 minutes in transfer of the cases. Majority of the time, if you have a STEMI, patients are not being transferred to a center, or if they're transferred, it's the time is more than 120 minutes. Why is this? Because of the multiple processes that are involved in the semi-care of the case. So we have created this app, how we can use this app. As soon as the EKG is done, it's transmitted to the interventional cardiologist. There's a chat group between the ED doctor, cardiologist, and they can enter some important medication. The most important is you can track the ambulance anywhere in the New York City and you know exactly where the patient is. So this is where our number was before transfer, about 70% or so patient reach less than 120 minutes. But after having used the app, more important is education, that 100% of the patients are reaching less than 120 minutes in these cases. So this is the same thing, past average of door in, door out. Door in, door out, based on the Mission Lifeline registry, has to be 40 minutes. We barely are reaching there, but we have still made it to 52 minutes. But door to device in the past was 120 minutes, but now we have made it to close to 90 minutes, just like the patient presented to our ER. So what is the future? The future is using technology, that EKG is performed no matter where, and using this kind of machine learning technology, it can go up and then understand this is a STEMI, and entire hospitals which are very close to will be activated, saying that there is a STEMI nearby. Now, many times when the patient is coding or something is happening to the patient in the field, people are not able to text or say something. So voice recognition is something that we are working on, so that if the ambulance people are able to talk to the interventionalist directly. So what is the future? That you combine STEMI, and if there is cardiogenic shock, we will know the shock team has to be alerted. So that would be the future goal, that this is exactly what's going to happen, that the shock team will be ready in the hospitals, so that you have interventional cardiologists that is directly activated. So the middle person, which is ED, will be removed. You go directly to the cath lab. So if you think patient is in cardiogenic shock, all that team is there and they're ready for insertion of whatever device that is needed. So this is where I think we have to improve. So take-home messages: that cardiogenic shock has a high in-hospital mortality rate, necessitating point-to-point assessment and timely utilization of a temporary mechanical circulatory support and its de-escalation. And that is where our app could help. Now, app technology provides to address the unmet needs in managing cardiogenic shock. The future direction involves integrating shock algorithm, team alert system to further enhance management strategies. So these are all the various apps that we have created, mostly for interventional cardiologists. These are free to be downloaded. The new one is a device one that we are already out in the App Store to be downloaded. Thank you for your attention.
Thank you, Anu. Fantastic, fantastic